Hi guys, Dr. Sander here from iMedics. Today's short video is going to be on acute epistaxis and specifically how to manage an acute epistaxis. So a nosebleed, which is what an epistaxis is, essentially is a condition that we can see in primary care, and of course you can see it in secondary care as well if you're working in A&E or in ENT. It is very important, so of course I'm a GP, but during my GP training I did do an ENT post for 6 months, and we would see a lot of nosebleeds that would be referred to us from either general practice or indeed from the A&E department, and it can be a life-threatening emergency, so you do have to be very vigilant when you're managing someone with an epistaxis. And of course, assess them appropriately so that you can identify what risk they have and then go on to manage appropriately. So epistaxis, as we've mentioned already, essentially it is what we call a nosebleed, and normally it occurs because there's been some damage to the blood vessels in the nasal mucosa, which of course then leads to a bleed. The causes, so normally it is a self-limiting condition, so it's quite common when we see patients who've got a nosebleed, we don't find out the cause, and most of the time they get better and they don't have any nosebleeds again, or they may have small nosebleeds every so often. But there are other causes that we should be mindful of when we're assessing the patient. You've got local causes, and that can be things like trauma. So whether it's a sports injury, picking the nose excessively, some people can end up with a heavy bleed after doing that. You can get use of topical drugs, so localized drugs, especially topical corticosteroid nasal sprays that are commonly given for other conditions like rhinitis and polyps and so forth. They can thin the nasal mucosa, and that can lead to a nosebleed as well. You have got some conditions that can be quite rare, but you've got things just to be mindful of, like the condition hereditary hemorrhagic telangiectasia and Wegener's granulomatosis. And in rarer cases, you can also get cancers as well, so things like a squamous cell cancer in the nose. So these are just things that you should be mindful of. There are other generalized causes that we should also know about, and things include hypertension, and blood pressure is very important when you're assessing a patient with epistaxis, because if they're hemodynamically compromised, i.e. they've got they're hypotensive and they've got tachycardia as well, well, we're worried that this patient is going into shock, and that of course is a medical emergency. So blood pressure is very important to check, because chronic hypertension can lead to recurrent nosebleeds, and it might be that you need to manage the underlying hypertension to correct the recurrent nosebleeds. So check the blood pressure. Other things, so there can be drugs, more systemic drugs that patients will take that can trigger off a nosebleed, like antiplatelet drugs and anticoagulant drugs as well, like warfarin. Then you've got rarer, so we've got hematology-based conditions, so things like leukemias, you've got haemophilias, and you've got thrombocytopenia, which of course is a low platelet count. So they're things that we should be mindful of as well. Chronic alcohol abuse can also be a trigger for nosebleeds. So again, be mindful of that when you're taking a history, if that's a history from the patient, or a collateral history to work out if there's any triggers within the patient's sort of kind of lifestyle and so forth. So in terms of how to manage it, so the first thing that you have to do is, of course, basic first aid. So you assess your patient. If they're not hemodynamically compromised, we need to make sure that we're in a state where we can actually manage them in primary care. If they're hemodynamically compromised, they need to be rushed urgently to the A&E department, and they need to be assessed by the ENT team, where they're most likely going to have their nose packed from there on in. But in terms of primary care, so what can we do? So the first thing is you need to do the first aid. So the first aid essentially is you pinch the soft part of the nose, so not the bridge, but the soft fleshy part here, and you ask the patient to sit forward, okay? And they need to sit forward and keep their mouth open so that they carry on breathing. And of course they can spit out any excess blood. It stops too much blood accumulating at the back of the throat. And it's a sensible way to manage and get the bleeding to stop. They should hold that position, so pinching the soft part of the nose, for 10 to 15 minutes, after which the bleeding should stop. If it doesn't, we now need to be thinking immediately about getting them into hospital, because they may need to have their nose packed. Now, the NICE guidance is interesting because it does say in primary care, if you have the expertise, so for example, you have GPs with a special interest in ENT and they've got the facilities, then they can do cautery or pack the nose if they can identify a bleeding point in primary care. But for many GP surgeries and many GP doctors in general, they would refer the patient to A&E for further assessment and treatment. If after the basic first aid, the nosebleed stops, we then tend to go on to the second step, which we should do as well to prevent crusting of the nasal mucosa and prevent vestibulitis. And that's offering a topical cream. And the commonest one that we give is something called Naseptin, which is a combination of chlorhexidine and neomycin. And normally the patient applies it to the affected nostril or nostrils. One application 4 times a day for 10 days roughly, but if the compliance is an issue, you can tell them to apply it twice a day, but then the course is going to be 2 weeks rather than a short course. So that should of course settle the bleeding. Then you give them the advice again about the basic first aid. So teach the patient, teach anybody else who's come to the appointment with them so that they can manage it, and then when to seek help, because if the bleeding doesn't stop after basic first aid, immediately call an ambulance for assessment in A&E. For more recurrent cases of epistaxis, so some patients will keep coming back and they keep having bleeding, what we tend to do is we offer them nasal cautery with silver nitrate, and that's where you do a nasal speculum, you look for the bleeding point, and that little paste, silver nitrate paste, is applied and you cauterize that bleeding vessel. And again, that can be done in primary care if you have the expertise. Otherwise, the ENT team normally has an outpatient clinic that you can refer to, and they can do the procedure there. And sometimes some patients end up on Naseptin cream every so often as well as a preventative measure for recurrent long-term nosebleeds. The other important learning point to take home is that you can very rarely get what we call a posterior nosebleed. These are very difficult to spot, but there are 2 key things that will point towards a posterior epistaxis. The first thing is that the patient will be bleeding from both nostrils. And secondly, the bleeding is so heavy that you can't identify a bleeding point on nasal speculum. Either way, when you spot or you suspect a posterior nosebleed, it's an urgent referral to the ENT department. So that was a short video on epistaxis, specifically acute epistaxis with a little bit of chronic epistaxis management as well. We'll make some more videos on this and other topics for you as well. And we've got a lot more revision videos, learning cards, and sort of questions and so forth as well. If you go onto our social media channels, you've got Instagram, inspire_medics, Twitter, which is also inspire_medics, as well as our Facebook revision pages for PLAB 1 and PLAB 2 exam preparation, and the MRC GP and AKT CSA revision groups. So do join them. I'll put the links down below as well, and I will catch you guys soon.